Yes, Dr. Utkarsh. Come.
Good afternoon, everyone. I'm presenting my paper on comparison of IOL Master 700 and manual keratometry in visual outcome on monofocal toric implantation. Introduction. The refractive power of the eye is determined by the cornea and the lens, and whenever there is cataract formation, there is decrease in vision, and cataract surgery is the most commonly done surgery worldwide. Nearly 60% of cataractous eyes have at least 0.75 diopter of corneal astigmatism, and out of them, 40% of those have corneal astigmatism of 1 diopter or more. And not correcting the astigmatism component at the time of surgery leads to failure of achieving spectacle independency. Various studies have shown that 20 to 28% of eyes have total corneal astigmatism different from anterior corneal astigmatism by more than 0.5 diopter or more than 10 degrees. This study evaluates the what differences are seen in the final outcome of toric implantation if we consider total, that is anterior plus posterior astigmatism by almost 700 or only anterior corneal astigmatism by manual keratometer. This was a prospective intervention study. It included the 40 eyes of 40 patients. Inclusion criteria was immature cataract or astigmatism of more than or equal to 1.5 diopter. And the exclusion criteria was mature, hypermature, or traumatic cataract. If there was any corneal opacity or any posterior segment pathology or any history of amblyopia or trauma. Patients were randomized into two groups. After the basic investigations, the keratometry was done by in group A, it was done by IOL Master 700, and the group B, it was done by manual keratometry. And the biometry was done by IOL Master 700 in the both the groups. On the basis of that, surgery was done and toric were implanted, and all surgeries were done by the single surgeon. In the results, the 40 eyes of 40 patients were included. The group A, that is IOL Master 700, in that mean visual acuity was 0.13 logmar, and the group B, that is manual keratometry, it was 0.20 logmar, and the statistical difference was non-significant. In terms of residual astigmatism, in the IOL Master group, it was 0.13 diopter, in the group B, it was 0.59 diopter, and it was statistically significant. And in terms of keratometric error, in the group A, it was 0.105, and the group B, it was 0.131, and it was non-significant. On comparing the vector components of all 40 patients by IOL Master and manual keratometry, the J0 and J45, the differences between them were non-significant. Discussion. As a result of technological developments in the cataract surgery, it is now very minimal invasive and increasing significance of refractive outcomes. To optimize the visual outcomes and minimize spectacle dependence, both the spherical and cylindrical components of the refractive error must be addressed. Our results were similar to Ailmeger et al., who in 2013 described in their study about J0 and J45 with IOL Master and manual keratometry, and in their results, the mean difference was statistically insignificant. Hassan Razmo in the 2017 blinded toric oil in the 55 eyes of 45 patients, and in the terms of uncorrected visual acuity, their difference was also insignificant. Menuk Chang et al. In 2014 introduced the term keratometric error. He said that since the toricity of IOL place also influences the post-operative astigmatism, so they hypothesized that this would provide the greatest accuracy in residual astigmatism determination. In 2014, they implanted toric oils in 25 eyes with measurements from manual keratometer, IOL Master, Pentacam, and auto keratometer. Their results showed that manual keratometer was the most accurate, but the differences between the instruments were not statistically significant. To conclude, overall, our study says that IOL Master 700 and manual keratometry gave the comparable results. While also considering the cost efficiency, it comes down to user affordability. If IOL Master 700 is available, it should be preferred for more precise results. If not, manual keratometry is already giving the almost equivalent results. Thank you.
First thing is you are not non-ratified member, they have mentioned, so we'll not be judging you, right? Yeah.
So questions must be there.
Yes.
You have after doing the keratometry, you implanted toric oil in those cases. Then you compared.
Yeah, I implanted toric oil in the both the cases.
Which oil we compare? Toric oil.
Alcon monofocal toric oil.
So all having same oil.
No, there was not the same IOL. See, our inclusion criteria was the astigmatism study more than 1.5 diopter. So our patients were from 1.5 to almost 5 diopters.
Same
astigmatism.
make IOL. That's
Yeah, same maker. Alcohol.
A few questions. Number one, the posterior keratometry, how much it contribute in the total keratometry value?
See,
Because IOL Master 700 gives both and give you the ultimate, what is the total corneal curvature.
yes, sir.
And the manual is giving the only the anterior.
See, the various studies have shown that in 20 to 28% cases, the total corneal astigmatism is different from anterior corneal astigmatism. It can increase the total amount of astigmatism, or it can also decrease the amount of astigmatism. But
So in your study, in the keratometric values, what is the difference between the two groups?
we
Average difference.
we have
total-
seen the differences were there, but we haven't not studied what is the exact
No, the difference was significant enough that. See what he's saying, you have only the anterior keratometry readings and you have both anterior and posterior. So was it significant enough? That's why you did the study.
in the pre-operative in the pre-operative data we did not compare it, but in the results the residual astigmatism was a significant difference, but in all other parameters
But ultimately,
it was
you
not.
are doing the axial length by the IOL master.
Excellent by the almost.
All right, so you cannot get rid of IOL.
I have a question.
700.
Just a minute.
IOL master only
No,
Yes.
we tried to
comparing
do
the astigmatic part.
They compared me one time.
Yeah. I have the same question.
Okay, thanks.
See, you actually said that it is due to that non-availability of the machine or the manual keratometry you are doing, but you are putting the same value again in an IOL master. So you have an IOL master. That means.
And that means he cannot get rid of.
I
Yeah.
wanted to stable the other factors so that
Okay.
Because we-
It is the IOL master 700 anterior, and they also suggest to keep one manual keratometer handy with you. In
yes,
cases of
because of
much
traumatic cataract, in those
controversy,
doesn't work.
you go to the final verdict from the manual keratometer.
Yes, when you have 2-3 different readings for keratometry from, say, you have done a pentacam, it is for
Anterior.
post-refractive cataracts.
Yes.
So you do have different, and then you are all confused. So one more thing can be added. And you have compared only the keratometry part.
Alright.
But anyway, we need other things. That's perfectly fine.
There have been studies which have shown that in terms of biometry, but this was the first one I think in which we
For
compared
the keratometry.
Be
That's right.
rectified now and do the study on your own
Thank you, sir.
shoulder.
Yeah.
And prepare all the questions ready for your next presentation.
Thank you, sir.